Okay, Dr. Ali, respiratory distress. What do you see?
I have been presented with frontal radiograph for skeletally immature patient. I can see that the both epiphysis center is not presented, meaning this patient is premature.
Good
I can
start.
see that, yes, I can see that the nasogastric tube is seen under the diaphragm in the expected location of the stomach. And I can see that
Good.
nasogastric tube is also noted in good position. The main abnormality that I can see
You
that,
mean endotracheal tube is good
yes,
and nasogastric
nasogastric
tube
tube
is good.
is
But
good, yes.
remember to look for other tubes.
Yes, such as umbilical or
Yes,
venous
good.
and arterial catheter. There is no, because I cannot see from the brightness of the image, but
Oh,
I think there is no
no problem.
umbilical or venous.
Yes, yes. There is one umbilical venous just below the diaphragm, 1 centimeter. I'm not sure if it's well seen or no. And we have also one umbilical arterial caster. It's okay. In my routine practice, I will adjust the setting. If you suspect any, till the examiner, I'll adjust the
Yes.
setting to yes to determine its location. But it's important in this age group to look for umbilical catheters. Okay, it's very important. Here, the umbilical venous low lying, and low lying umbilical venous catheter carries the possibility of
Two possibilities. It could lead to thrombosis within the portal vein or its branches, and could
good.
be lead to uh, catheter uh, catheter bioma or something like this.
TBN noma,
TBN
TBN
noma,
noma. Yes, yes. Acute
TBN
hepatic
noma.
blood collection due to injection of
Yes, yes.
parenteral fluid through the caster. Excellent, my friend. Any additional devices or anything else before we start?
Yes, I noticed that there is calcified opaque structure seen in the mediastinum, but the rest are ECG leads.
Good.
I can
It's
see
not
two ECG.
calcified, it's a medical device. Okay. At the junction between the aorta and the pulmonary. So could represent,
Between the closure device of the
yes,
uh,
BDA,
beta
BDA.
ductus arteriosus.
Excellent, excellent. BDA closure device. Very good, my friend. Okay, now to the chest, respiratory distress.
Yes, this patient is presented with multiple uh, oval and rounded cystic lesions that arising from the hilum, and I can see that there is decreased volume of the left lung. If the
Good.
patient is known case of respiratory uh, distress syndrome, I am thinking about pulmonary interstitial emphysema,
Excellent,
which is occurred
excellent.
due to
Leakage of fluid into the interstitium.
for the history of previous.
Uh,
Yes,
uh,
so I will ask if there is any history of respiratory distress syndrome. However, I cannot see any pneumothorax. There is no pleural
Excellent.
effusion,
Good.
and there is no shifting of mediastinal structure, and there
Good.
is no cardiomegaly, no underlying bony pathology. So my impression is this is a case of pulmonary interstitial emphysema in a patient known case of respiratory distress syndrome. I will urgently confine my finding to the referral doctor, communicate with the in neonatal ICU to adjust the ventilation settings.
Excellent, excellent, Dr. Ali. Excellent, Dr. Ali. Since this child is preterm and this is a start, okay, please assess the age of the patient. Absence of ossification center of proximal humera, plus or minus some prominence of subcutaneous fat. It means preterm baby. Presence of endotracheal tube. It means severe distress with hypovolemic lung, most likely respiratory distress syndrome, surfactant deficiency syndrome. Presence of lucencies, okay, predominantly linear or rounded, bilateral, rather symmetrical. By the way, some obliquity is present, non-centralization. This is a cause of difference in lucency. It's one of the complications of ventilation, barotrauma, I mean. It's important to rule out other chest emergencies like pneumothorax, pneumomediastinum, all related to barotrauma. Management adjusts the settings of ventilation. Excellent, Dr. Ali. Good start. Now, the abdomen, neonate with some distress. What do you see?
This is a babygram for premature patient because I cannot see the epiphysis center of both humeri.
Good,
I can see that there is a nasogastric tube seen under the diaphragm in good position. There is nasogastric endotracheal tube also seen in a good position. The main abnormality that I can see, there is a significant dilatation of the proximal and distal bowel of this
good,
patient associated with mottled appearance within the wall of the bowel representing pneumatosis intestinalis. However, I cannot see any free gas. There is no pneumoperitoneum. And
good.
in my routine practice, I will zoom the area of the liver to see if there is any.
Excellent. Excellent. This
Yes,
is important point. Why I'm looking for a portal venous gas. So I'll do a zooming.
zoom. Yes.
I will do it for you. Do you see any branching gas lucencies overlying the liver?
No, I cannot see
Okay,
any.
I will adjust the setting. So zooming and adjustment of the
The
setting.
window. Yes.
Yes. Mm. Do you see any
Yes, I
now?
can see that. Now I can see that
Good,
there is
good.
branching tubular structure within the liver
Excellent.
representing, yes,
And this is the mottled appearance you
yes.
talked about. Very good, my friend. Okay, continue, please.
Yes, I also noticed that there is granular ground glass opacity noted at
Excellent,
both
good,
lungs, and as the patient is in endotracheal tube, this is meaning this patient is also having respiratory distress manifested by respiratory distress syndrome. So I will correlate with the maternal prenatal history, and also I noticed that there is um, no free pneumothorax or pneumomediastinum.
good,
Uh,
good.
yes. So,
If suspecting some pneumoperitoneum, how to be sure if it is present or no?
I
Anything
will
else you
put,
can do?
yes, I can put the patient on the lateral decubitus position.
Excellent, excellent. We
Yes,
have two possibilities, either lateral decubitus or dorsal decubitus. Very good.
yes.
Do you see anything else?
No,
Good.
sorry. I can see that there is a free gas
Where?
noted in the dependent part.
Free gas in the dependent part. Gravity, Dr. Ali, gravity.
Gravity.
Okay.
It's supposed to go out above.
Yes, yes, yes. The right side should be up in case of lateral decubitus. So I'm looking for any gas here. And the free gas will be يعني seen here in the
Mm,
most upper cut of the radiograph.
mm,
And if there is diffuse ascites, it will be seen here as a dependent continuous opacity. Okay, but here no ascites, just fluid level within the bowel. Very good, my friend. So, and you see, my friend, what is this?
This is an pneumatosis
Yes,
intestinalis.
it's very clear. Gas
Clear, yes.
outlining is about very good, very good. Back to our radiograph. So, your final diagnosis and management.
My final
Hmm.
diagnosis is necrotizing enterocolitis,
Good,
complicated by portal vein gas. There is
good,
no obvious perforation or pneumoperitoneum, and
good,
respiratory distress syndrome in a premature baby.
good. Management.
Management, I will urgently confine my finding to the neonatal ICU. I will keep monitoring and follow up radiograph for this patient for every 12 to 24 hour in case of no perforation, and also
To
support
12
by
hours will be enough. 24 is something much. Okay.
yes,
So,
every 12
here,
hours.
yes. If we are following a chest problem, we can do a follow-up every 24 hours. This is a question, by the way. If we are following abdominal problem, we are looking for any perforation. So 8 to 12 hours will be enough. Excellent, my friend. Since the child is pre-term, okay, we have to look for two main pathologies in chest, respiratory distress syndrome with its complications, in the abdomen, necrotizing enterocolitis with its complications. Few questions here, Dr. Ali. You said small and large or proximal and distal. Correct?
Yes, yes.
Can you differentiate proximal or distal or small and large bowel in this age group?
I cannot differentiate between
Very
both of
good,
them.
because of immaturity of the valvular events at this age group. Very good.
Yes, yes.
So, with multiple, more than three dilated bowel loops, we call this distal bowel obstruction. Okay.
Yes.
Okay, how to judge the dilatation of the bowel loops in neonates, in elderly or an adult person, the height of the vertebral body. But here,
Here I will compare it with the diameter of the uh, vertebral body.
yes, interpedicular distance. Interpedicular
Perpendicular
distance,
distance.
not the vertebral height. Why not the vertebral height? Because it's a neonate. Upper and the vertebral end plates is still cartilaginous. Okay, cannot be seen. But the pedicles already ossified, especially L2. So I can judge the dilatation by measuring the interpedicular distance. Excellent, Dr. Ali. I'm not sure if something happened to this child again. Let's see. Let's see. Ah, one of the possible complications happened because this child underwent something like distension or obstruction. So we performed a contrast enema that revealed stenosis or stricture in the colon. It's one of the known complications. Just a rapid review of the stages of necrotizing enterocolitis, usually starting as fixed dilatation. How to know if it is fixed or no? By follow-up. The same pattern will be present, followed by pneumatosis intestinalis. Look for any motile lucences. Motile lucences in older child or adult can be related to fecal matter. It's a normal phenomena. But in neonate, no fecal matter. Any motile appearance, it means gas in the wall, pneumatosis intestinalis. The next stage is portal venous gas. Portal venous gas in adult person is a very dangerous sign. It's fatal, actually. Okay, it means mesenteric ischemia. Okay, small bowel ischemia. But here in neonates, it's okay. It can be resolved completely, and this child will do well, inshallah, later on. The next stage is perforation. Look for free gas or free fluid. We will see, inshallah, free fluid with the next candidates. Okay, I'm trying to explain as much as I can. Okay, the last case will be easy one, Dr. Ali. Okay, what do you see?
Yeah, this is a radiograph for the right lower limb for a skeletally immature patient. I can see that there is a transverse fracture seen involving the uh, shaft of the right femur bone. I can see that the bone itself
This
appears
child
extensile.
presented with, sorry, swollen lower limb, absence of history of trauma, so suspected physical abuse.
Okay, but I can see that there is uh, expansile dilatation or enlargement of the proximal right femur,
Good.
and there is suspicious of fracture seen in the midshaft
Yes.
associated with sclerosis,
Good.
and I cannot see any expansile or enlargement seen within the tibia or fibula bone.
Good.
So, in my routine practice, I want also to see the orthogonal view for this patient, if available.
Okay. It doesn't add much, but it's okay.
Much.
Yes.
Yes.
So what is your opinion?
In my opinion, this could be due to osteogenesis imperfecta,
Excellent.
manifested
One.
by fracture
Yes.
of the, yes. Other differential, it could be due to non-accidental injury. So I will continue viewing the skeletal survey to see if there is any evidence or signs of non-accidental injury. Other differential diagnosis, it could be due to other yeah, syndromatic disease or
Okay.
um,
So they are
yeah,
suspecting non-accidental injury. Yes or no? With
no.
this classic, yes, it's osteogenesis imperfecta, one of the mimics of non-accidental injury. But all bones is osteopenic, severely
Yes.
osteopenic, and gracile bones. And this fracture long standing. And usually, if we do skeletal survey, we'll see a multiple healed fracture, excessive bowing, and the same pattern. One of the mimics, of course, this is older child, but if a younger age group, one of the mimics of non-accidental injury is osteogenesis imperfecta. Another mimics, it can be rickets. Inshallah, I'll cover it later on. Thank you,
Thank you.
Big Boss. Thank you, Dr. Ali. Good start, yeah,
Thank you.
boss. Good start. Okay, the next candidate.
Yes, doctor.
How are you, boss?
I'm fine.
Okay, respiratory distress.
Okay, I'm presented with the frontal chest radiograph of a skeletally immature patient that appears to be premature due to the absence of humeral epiphyses.
Good.
Okay, the manifest abnormality I can
Yeah.
see is the
Lines and the tubes.
oh, okay, lines and tubes.
Yeah.
There is an applied endotracheal tube that appears to be in a good position.
Okay.
Uh, there is a
Reflecting
nasal.
element of significant respiratory stress. Okay. And
Okay, there is a nasogastric tube with its tip projected upon the gastric air shadow,
good.
reflecting proper positioning as well.
Good.
There is a few chest leads indicating critically ill patient.
Excellent. Good.
I cannot see any umbilical venous or arterial catheters in
Good.
this
Good.
study.
Good, my friend.
Okay, the main abnormality is the presence of ground glass, diffuse ground glass opacification of the left upper and middle lung zones. Okay, there is also apparent widening of the mediastinum, however, convex towards the right. However, I think this is normal thymic tissue.
Good. Good. So
Uh,
this is normal thymic tissue, and
okay,
this is abnormal.
yes.
So the main abnormality on the left,
On the left, the upper and mid lung zones.
you suspecting opacity, correct?
Yes.
Anything else?
Okay, I cannot see any. I'm checking if there is any signs of pneumo. Okay, I think there is a rim of right-sided pneumothorax. There is a pleural visceral pleural line
Good.
with
Good.
a lack of lung markings lateral to it. Okay, so I.
Even if you don't see this plural line, I
Mhm.
brought you this case because of sharpening of the border.
Oh,
Sharpening of the border of the mediastinum,
okay.
sharpening of the diaphragmatic border,
Mhm.
indicative of pneumothorax even without any pleural line. Okay, in
Okay.
neonates, don't expect to see a clear pneumothorax except if massive. Subtle
Okay.
finding like asymmetric lucency or sharpening of the border is very concerning for pneumothorax. This is number one. Number two, if you're suspecting opacity, what could be, my friend?
I think this could be part of the thymus as well.
Yes, excellent. I
Mm.
still see some bronchovascular marking can be seen
Bronchial.
through this lesion. In this age
Mm.
group, it can be thymus. It can
Yes.
be thymus. Okay.
Okay.
Because if you said it's opacity, what could be? Ask yourself, what could be? A diaphragmatic hernia, intact diaphragm,
Mm.
normal bowel.
Mm.
C BAM should be lucency, even
Mm.
intermingled with opacity. But where
Mm.
are the lucencies?
Yes.
What else? Congenital lobar overinflation early in life.
Mm.
Okay,
Mm.
it's not early since I can see some bowel gases. By the way,
Mm.
my friends, congenital diaphragmatic hernia, CBAM, lobar overinflation, all will appear opaque if the child immediately imaged after birth.
Birth.
After a couple of hours, maybe just 2 or 4 hours, all will
Mm.
be filled with air and
Mm.
diagnosis will be settled. Very good, my friends. So it's a pneumothorax, okay?
Mm.
If suspecting pneumothorax, I'm not sure what to do next.
Okay. A tangential beam, horizontal beam, X-ray, lateral.
Excellent.
Okay,
Excellent,
lateral
my
view.
friend. Excellent.
I'm expecting to see the air in front of the cardiac shadow
Good, good.
and along
So
the anterior aspects
the
of the diaphragmatic domes.
Good, good, good. Again, the cubitus and the air will rise up by gravity. Very good, my
Mm.
friend.
Mm.
We may indicate يعني urgent clinical assessment and possible endo chest tube placement. Okay, and
Mhm.
again, adjustment of the ventilation settings.
Okay. Is there
Abdomen.
a cause for the intubation and in the previous case?
No, just respiratory stress. Just
Okay.
respiratory stress. Okay.
Okay.
One of the, okay, let's
Mm.
revise. Causes of respiratory distress in this age group. We have medical treated causes and surgical causes. Surgical causes, my friends, okay, usually unilateral, like congenital diaphragmatic hernia, CBAM, and.
Mm.
Medical causes bilateral, rather symmetrical. The most common, if a preterm, will be respiratory distress syndrome.
Yes.
Others, like what, my friend?
And preterm?
I'm not
Uh,
sure. Yeah,
um,
maybe, yes.
um,
Transient tachypnea of a newborn. Okay. Wet
yes,
lung
okay.
syndrome due to cesarean section also can be
Mm.
preterm, but
Mm.
usually milder form of respiratory distress. Doesn't
Mm.
necessitate
Okay.
endotracheal tube.
Okay.
Okay.
Mm.
Others can be neonatal pneumonia. The last one, meconium aspiration syndrome. So we have a
Mm.
four medical cause. Meconium aspiration usually term baby or even post date.
Mm.
Okay. And
Okay.
difficult delivery and usually associated with opacities, tiny
Yes.
opacities, cord-like opacity. So it's different. And the volume of the lung will not be reduced. Totally different. But it's severe distress that also necessitates endotracheal tube.
Okay.
Good. I will revise this cause again with a surgical team. Okay. Abdominal case.
Okay, I'm present.
Neonate.
Oh.
Yes. Okay, proceed.
In
Okay.
history.
Some abdominal distension with mild distress. Okay, what do you see?
Okay, this is a frontal radiograph of the chest and upper abdomen of a premature baby. Um, okay. First, I'd like to comment on the lines and tubes. The endotracheal tube appears to be high above the expected site. I would convey the findings to the referring physician to replace the endotracheal tube. There is
Okay.
nasogastric tube with its tip projected upon the gastric air bubble as well.
Good.
indicating good positioning. Okay, there is a umbilical arterial catheter that appears to be in a good position, opposite almost T10. Okay, there is, I think there is umbilical venous catheter that is malplaced with its tip projected below the diaphragm
Good.
at the over the hepatic shadow. Um, okay, there is a few other chest leads and a radio-dense structure. I'm not sure.
It's
I'm
okay.
not
It's
sure.
okay. Okay.
Okay,
Okay. Can be external. Okay. But here it's misplaced umbilical
a venous catheter.
venous catheter. Very good. Very good.
Okay.
And
Um, okay. Multiple air shadows projected over the hepatic dome.
good. Good. Yes. This abnormal gas lucences. Okay. Bizarre shaped gas lucences project over the liver shadow. Very good.
Uh, okay, I'm not sure
Can be
what.
one or can be two. Two differential.
Okay, those could be yeah, air injected through the umbilical venous catheter within
Okay. Very
the
good.
hepatic
Very good.
parenchyma.
So
Um,
iatrogenic. Yes, it
uh,
means iatrogenic. Very good. During
yes.
the injection. If recently placed catheter, what
Mm.
if I told you the catheter introduced yesterday or 2 days ago?
Okay, forceful injection of fluids can cause this. I'm not sure.
No problem.
There is no
Remember,
enough
it's
time
okay.
for thrombosis to occur.
It's okay. It's okay.
Mm.
Dr. Ali said two complications for misplaced umbilical venous catheter.
Okay.
Portal vein thrombus
Mm.
and acute fluid collection. What can
Mm.
happen to the fluid collection?
Secondary infection, abscess
Yes,
formation.
yes, abscess
Mm.
formation. Excellent, excellent. And
Mm.
if linear, I can suspect portal venous gas, especially I'm suspecting preterm, and I will need to image the abdomen.
Mm.
Okay. By the way, chest looks fine. Okay. Very
Okay.
good. So you are suspecting infected collection or abscess.
Mm.
What
Mm.
you will do
I
next?
will urgently convey the findings to the referring physician and recommend the ultrasound examination.
Okay. By the way, abdominal radiograph here because if this is a portal venous gas
Mm.
versus infected collection, it's
Mm.
advisable to image the abdomen.
Mm.
Okay, maybe necrotizing enterocolitis, but bizarre shaped rather than linear shape. Okay,
Mm.
so in the abdomen, no mottled gas,
And
and
the blood.
again,
Mm.
no free gas.
Okay.
Even here, my friend, when you are looking at the chest, rule
Mm.
out chest emergencies. What are the chest emergencies? No pneumothorax, no
Mm.
pneumodiastynum, no
Mm.
pneumopericardium. Okay?
Yeah.
Okay. In the abdomen, no definite portal venous gas, but I'm suspecting gas over the liver. Maybe portal, maybe others, but
Mm.
no free gas, no pneumoperitoneum. What are the signs of pneumoperitoneum in this age group, my friend?
Pneumoperitoneum, the falciform ligament, the
Excellent.
football sign.
Excellent again.
Okay,
Continuous diaphragm sign.
a continuous diaphragm sign and the regular sign.
Regular sign, yes.
And there might
The
be
most important and subtle finding and easily missed, abnormal diffused lucency overlying the liver.
okay.
Abnormal lucency overlying the liver. So I can see the abdominal wall. Here I cannot see the abdominal wall because it mimics the same opacity as the liver. If
Mm,
you see the abdominal wall opaque, it means diffuse lucency overlying the liver. Common
mm,
and easily missed.
okay.
Okay, my friend, as you said, we did ultrasound for the liver that showed
Showed an anechoic heterogeneous collection with marginal hyperechogenicity and marginal increased the color Doppler flow, indicating hepatic abscess secondary to malplacement of the umbilical venous catheter.
Excellent, excellent. Yes.
Okay.
Collection containing some air foci. It can be infected collection, but this is the normal vessels. Okay.
Okay.
Okay. It's called acute hepatic fluid collection, TPN NOMA. Total parenteral fluid, and OMA means total parenteral nutrition. OMA means a collection. And secondary infection. If recently introduced, it's okay. This gas lucency will disappear within 1 or 2 hours. Excellent, my friends. Now